Hello everyone, this is Dr. Manish Kothari. I'm a spine surgeon at Jaslok Hospital, Mumbai. Today we are going to discuss about patient positioning in spine surgery. Mostly it will be about prone positioning. Now, a good position will make your job easy and perfect, just like a perfect cover drive. But an improper position can land you in soup. You can have unexpected complications. Now, just looking at the literature, you look at the number of studies published with regard to the number of complications. Just have a look at the complications. So there are so many studies regarding visual loss, conjunctival swelling, corneal aberrations, compartment syndromes of the eye, angle closure glaucoma, even double vision diplopia. There are many others regarding vascular complications like cerebral infarction, embolism, bowel ischemia, and so on. Then there are others which are common to other positions also, including which include nerve palsies, compartment syndromes, and this one particular position called the knee chest position has had the maximum number of complications. Now, to understand why these complications happen, we need to understand that prone positioning in general anesthesia changes the physiology of the patient. It causes a decrease in cardiac index. It increases the airway pressure, it increases the abdominal pressure, and causes unnatural pressure points. When the patient is positioned prone, there is the abdominal pressure causes increase in the inferior vena cava pressure, and through the Battson's plexus, this causes increase in your epidural pressure. These epidural veins are valveless, muscleless, thin-walled, very easy to rupture and difficult to coagulate, and cause a nightmare to the surgeons. It causes increased bleeding, poor operative field. You may not be able to complete your job. It causes the surgical duration will increase, and of course, all your pressure points will start becoming important as the time increases. Now, to avoid these, we need to be very clear regarding how to achieve a safe positioning. So the goals are that there should be adequate padding of all pressure points head to toe. The abdomen should be free. You should be freely be able to pass your hand under the abdomen and make sure it is nice and hanging. And you can even use the position to enhance or rather help you during the surgery. We'll see to it later. Now, when we talk about the position, the care starts right from the supine position when the anesthetist is starting the induction. For example, in this patient with ankylosing spondylitis, the trolley is straight, but the patient is given a contoured position as per the shape of his spine. Another example is patients with severe cervical stenosis. You want to avoid hyperextension during the laryngoscopy and the passage of the endotracheal tube. This can cause catastrophic quadriplegia. From now, turning the patient from supine to prone is a delicate process. It has to be a slow, smooth event with everybody in on the same page, and the lead is taken by the anesthetist who is holding the head. The head, neck, torso should move as one unit. It should be maintained in neutral position. The head should not twist while the body is being turned on one side. This is especially true in cervical stenosis or trauma patients with unstable injuries. Of course, all pipes have to be free, Foley's, your IV lines, your arterial lines, and so on. Now, once the patient has been positioned prone, you want to look at all the pressure points. The most important I would say is your eyes. They have to be very carefully positioned. The eyelids have to be shut and taped, or you can add some ointment. There should be absolutely no pressure on the orbits around the eyes. Some people use Mayfield and cervical tongs, which is perfectly fine. Make sure that the head is not dangling in any position. Use supports to keep the head and neck in neutral position. The head should be above the heart level so that there is no venous engorgement in the area in the through the superior vena cava and in the face. And when you are scrubbing the patient, make sure that none of the scrubbing agents trickle down into the eyes. This happens very commonly during posterior cervical surgery. This one position I would highly not recommend, should be avoided, is turning the head on one side, especially the anesthetist does that during lumbar surgeries. In the young flexible cervical spine, it may be okay, but for older and arthritic patients, this may be disastrous. There are better positioning systems available now very commonly. These are various ways you can for the headrest. I personally like to use this one with the mirror, where you can see the eyes of the patient through the mirror. Next, you want to look at the neck position. It should be neutral position as much as possible. You should avoid hyperflexion or hyperextension. Then we come to the shoulder. The shoulder should be in 90-90 position with about 20 to 30 degrees of forward flexion of the shoulder, not in complete, not in abduction. The problems in bad positioning it can cause brachial plexus injuries, shoulder pain, and rarely thrombosis of the vessels. Next, we come to checking all the bony prominences. You want to look at the elbow for your ulnar nerve. Make sure there is an axillary pad under the axilla. Similar, a good Gamgee pad or a gel pad to protect the lateral cutaneous nerve of thigh, protect the knees, protect the ankles, and the hip and knee should be in relative flexion for most of the cases. So pressure points should be avoided. This will become very important as the duration of the surgery increases. Now, other thing that I always like to talk about is to check the airway pressure. So always ask the anesthetist, what is the change in airway pressure from supine to prone? A very large change in airway pressure and a longer duration of surgery can lead to disastrous events. uh, the change in pressure can be because of bad positioning of the bolsters. If they are too close, then it will cause pressure on the abdomen. If they are too far away, then the patient will sink in between the bolsters and cause abdominal pressure. The ideal position is the anterior superior iliac spine is well rested in the center of the bolsters. You can also keep bolsters horizontally if you may wish. The patient should be relatively thin or rather not too obese. The next thing that I always also look at is the tidal volume. So a normal accepted values of tidal volume in anesthesia is roughly around 6 to 7 ml per kg. So if you see this, my patient I was doing a few days ago, he was a 60 kilos patient, but his tidal volume given was 50 and his airway pressure was 29. So I asked the anesthetist, can we reduce the tidal volume? He was very happy to do so. And once we've done the tidal volume to 450, there is a drop in airway pressure by 3, which is going to make very significant difference in my epidural pressures. This becomes very common or rather problematic in especially patients with large bellies. So a way to avoid or rather keep the abdomen free is use a knee chest position, but make sure that there is not too much pressure at the popliteal angle and there is support for the buttocks so that the weight of the body is not on the legs. Other way of doing this is you can stack up a few pillows, tie them up, and then keep your bolsters on top of the pillows to raise the height. uh, Other way, with especially with large short patients, I personally like to use these contoured bolsters, which are contoured for the thighs as well as the abdomen. Now we look at how to use the position to our advantage. So we can use something called as Wilson's frame for a microdiscectomy, where you can jack up the patient, but you should not do it too much. It should be very mild jacking up, just enough to open up the space. Otherwise, it will cause your increase in abdominal pressure significantly. Next, you can do the same thing by breaking the table a bit, about 20 degrees or so. That will give you good opening up of the thing. But it is reverse in a spondylolisthesis, where you want to give thigh extension so that that helps in your reduction during the surgery and you can achieve good reduction. If you're doing large tumors, then you want access in between the legs. which will give you a complete round of complete turnaround of the page of the mass. For posterior cervical, horseshoe is what many people use. But I always recommend that it should be used with some form of traction to stabilize the head. Otherwise, the head becomes too wobbly and it can cause complications. For example, this is my own patient. This was before the surgery where the patient was positioned and I had given traction as well. But you can see at the end of the surgery, the patient had slided down from right from where he was supposed to be to where he is now. Because he had traction, there was no major event, and the patient got away with this. I personally now like to use radiolucent Mayfield clamps, which allows complete access to your C-arm as well, and you can do all sorts of instrumentations. In an anterior cervical surgery, you want the patient to be raised above the table so that the C-arm the images can be seen properly. So you add a head ring under the head, bolsters in between the scapulae. You strap the shoulders down so that they don't obstruct your C-arm images, and you want to give slight extension at the chin so that the skin is stretched out and your access becomes easier. Other important point is that your C-arm management should be precise and well thought of before you start draping. Sometimes you get these extreme angles with the C-arm, but if your positioning is correct, it should not be a problem. You have to have enough distance to look at both AP and lateral and whatever views you want. Especially during an S1 screw, you need those extreme lordotic angles, and the base of the table causes a problem. For example, in this patient, I would absolutely not be able to take an AP view or whatever I try. So this should be planned well in advance. So to summarize, padding at all important points is necessary as we discussed. Make sure the eyes and the abdomen are free. For obese patient, you have to plan well in advance. Make sure your bolsters are of the right size and of the right density. Sometimes the bolsters are very soft and they will just sink down. Make sure your CM management is also taken care of. You should be able to see all that you want to see with the CM, and you can always make sure that the position that you give will aid your surgery. Thank you very much.